It's hard at the beginning when you're learning because of the learning curve and you're not as efficient. But ultimately, if we train all these residents and all these learners how to do whole up, it's sort of like Ali was saying, like how TURP used to be viewed as this really challenging case. That's how whole up was viewed. But all the residents at Wisconsin are learning it, and they are amazing residents. And I learned it in residency. It's clearly something that can be taught and learned in residency, and you can become efficient within your first few years of practice. And so I think like a lot of the arguments that people make are based on not having seen it or learned it or like been in a program where it's so present.
Hello and welcome to our WInnovations podcast. I'm your host, Dr. Kyle A. Richards, and we have a very cool and exciting program planned for today. We're now in our second season of WInnovations, and we're thrilled to be back in the studio in the Department of Urology here at the University of Wisconsin. Now I'd like to introduce my guests for today, Dr. Becky Gerber and Dr. Ali Antar. Now, Dr. Gerber is a urologist at Atrium Health Urology in Charlotte, North Carolina, where she has a special interest in the diagnosis and treatment of BPH. She did her medical school at Indiana University, followed by urology residency right here at the University of Wisconsin, where she graduated from our residency program a little over 2 years ago. And she even says in her bio, quotes, "The field of urology is consistently at the forefront of developing new technologies to improve patient care. I am proud to be part of the effort to improve the quality of life for my patients," end quote. And that just really epitomizes what we're all about here at WInnovations. And Dr. Ali Antar is an assistant professor here in the Department of Urology at the University of Wisconsin. He completed his urology residency at Baylor College of Medicine, followed by an endourology fellowship here in Madison. And I know both Ali and Becky personally, and I know that they are very passionate about the diagnosis, management, and comprehensive care for patients with benign prostatic hyperplasia, or BPH. And it's truly amazing to have these two thought leaders here with us tonight in the studio to discuss the topic for today, which is a new era in BPH management. And welcome to the program, Dr. Gerber and Dr. Antar.
Yeah, thanks for having us.
Thank you for having me. Good to be back in Madison, albeit virtually.
Right. Yeah, it's good to see you, Dr. Gerber. I know it's been a couple years since you finished residency here, but we have lots of fond memories of your time here, and I've heard really good things about you as you've started your practice in Charlotte, and Dr. Antar is one of our new faculty members. It's great to highlight some of his exciting work that he's doing, and I think has really started off as a great member of our department. Now, I like to start off by paying homage to our mentors. We all have mentors that helped us to sort of get to where we're at today. Let me start with you, Dr. Gerber. Who were your mentors that you'd like to pay homage to as we start this program?
Well, I think in terms of BPH and whole up specifically, I think the main, reason that I was able to be in the place that I am today is because of Dr. Dan Grelnick, who essentially, was able to go and learn this procedure at Indiana University and then brought it back to Wisconsin and really pioneered it at the University of Wisconsin. And if he weren't to have done that, I certainly wouldn't be in the place where I am today. And then while he was back at Wisconsin, he was able to help Dr. Chris Manikis learn the procedure as well. So those were the two people who really, helped me learn the technique and become more interested and involved and become proficient in it upon graduating residency. But I also, of course, have to thank you, Dr. Richards, because you were a big part of my surgical training. So can't leave you out. And then, of course, Dr. Nakata for just making an excellent program that I was privileged to train at. So I think those are, the people who I really respect and admire and have allowed me to become the urologist that I am today.
Well, thanks, Dr. Gerber. I wasn't expecting that, but very much appreciate being on that short list for you. What about you, Dr. Antar? Who would you say is on your short list of mentors that you'd like to pay homage to?
Yeah, it's hard to make a short list of people that taught you how to do the thing that you do for a living. At Baylor, I think the two that really taught me most about BPH, because when I was at Baylor, we didn't do whole-ups at all. We just did robotic simples. And the two that really taught me that procedure was Philip Ho and Richard Link. And Philip Ho was a semi-private practice at Kelsey-Seybold. For me, whenever I'm on the robot now, his is the voice in the back of my head. So I'm thankful for Philip for teaching me that kind of efficiency. And then Dr. Link for really being a no-nonsense kind of clinician and just being daring on the operating room. Because he mentioned it himself. He said, maybe if I came in at a different time, I would have done hold up, but I do robotic simples. It's just the way it is. And then when I got here, obviously Dr. Growlick, Dan, I mean, he's been so instrumental. Just thinking about what he did to be the only urologist doing whole lip and to go through all those tough times. I mean, it's a hard case if you don't know what you're doing. It's a hard case if you don't have other people with you in the room. And between him and Chris Manicus to really flesh it out into as streamlined a process as it is, it's a lot. So kind of building on the shoulders of giants. And I get to still build with them because they're still sitting in all the research meetings and we still get to publish together and have a lot of our ideas together. And then also just honorable mentions, not necessarily related to BPH, but Wes Mayer was the program director at Baylor, and he really got me this fellowship by emailing Dr. Best, so we should also put her on the list. And I'm sitting in her office, and Dr. Nakata for taking me on and teaching me everything that he teaches me. So he's just a wonderful mentor, all of them. But with BPH, yeah, it's definitely Dan. I think Dan's definitely at the top of the list. You can't thank him enough for doing what he did, bringing whole up to this place. It's absolutely amazing.
Yeah, Dr. Grelnick has taught the next generation, I think, of so many people that he's taught are now going out and doing it in the world, which is a really cool thing to have.
Yeah, it's very interesting to see how that's evolved, and we'll talk a little bit more about HoLEP later on. I know you guys are very excited about HoLEP, which is great, and we'll talk a little bit about learning curve as well. I'm curious to know your thoughts. I once asked Dr. Grelnick if he thought that I could learn HoLEP, and he said I don't think so. So I don't know what that says about me, but I think it says it's a pretty hard operation because I like a challenge. So, but we got to take a step back a little bit, I think, because sometimes people say, "Well, who's the audience for WInnovations?" And I think it's really anybody that's interested in innovations in urology. It could be patients, certainly other urology providers, but we have to sort of define what we're talking about, and that is BPH. So maybe Dr. Gerber, if you want to start, just for maybe some of our listeners that are not medical folks, what is BPH? How do you define that?
Sure. So BPH, it stands for benign prostatic hyperplasia, and it's basically when in men, all men have prostates, and the prostate is an organ that sits right beneath the bladder. So every time that a man urinates, the urine has to come out of the bladder and go through the prostate. And so as men get older, the prostate cells can multiply. And as they multiply, this creates more cells. And so the prostate, as it enlarges, can begin to block the tube, the urethra, where the urine gets out. And that can make it harder for men to pee and can lead for men to urinate. And that can make it harder for men to urinate. And then they develop symptoms like going frequently, waking up at night, having to get to the bathroom quickly, having a weak stream. And it happens gradually over time. So maybe men don't notice it right away, but it's sort of a gradual thing over 5, 10, 15 years that men begin to notice.
And Dr. Antar, this is a pretty ubiquitous common problem. Do we have numbers to know what percentage of men have BPH?
Well, this is where I really wish we had a librarian on with us and they could tell us for sure. They could search all the latest epidemiologic studies. But I think over the age of 60, and I don't have a specific number, but I'd say it's over 80%. I mean, it's always a small element of it, and it's hard to quantify. Because that's the other interesting thing about how do you make a hard diagnosis of BPH, right? Because hyperplasia is a histologic term. It's not like we get a biopsy and everybody say, "Oh, now you have BPH." So it's basically anybody who walks in the door and fills out an AUA symptom score and they have a bad enough score and bad enough complaints on their symptoms. Hey, you've got a prostate, you've got lower urinary tract symptoms, you're on that BPH spectrum. Let's talk about treatment options, right? So it's interesting to see what the different epidemiologic studies say.
I think it's interesting exactly what Ali was saying, that there's not a global consensus on the epidemiologic definition of BPH. And so when they're doing autopsies of men in their 80s, 85% or more will have BPH, but did those men have urinary symptoms like Ali was saying? And we don't really know. So it's sort of the combination of the two, and we don't have a good way to define that. But I think the answer is almost every man will most likely experience it at some point in his life.
It's kind of like that erectile dysfunctional thing, everybody after the age of 50% have it. After the age of 60% have it. I don't know if BPH falls in the same, but that's what Dr. Carey used to say all the time. So
yeah, it's certainly true. I think the BPH, ED, erectile dysfunction, BPH go hand in hand. It's just a common part of aging, the aging male. We did an episode earlier with Dan Williams and Helen Burney on sort of men's health, talked a lot about ED and lot of similar themes I think are coming up in this discussion. So Ali, then you've got this patient in your office that you have made the diagnosis of BPH on. So what is your approach then? How do you discuss that with the patient and how do you move forward?
It's a very interesting patient population we have here at the University of Wisconsin. It's not like I'm getting the 50-year-old guys. It's just like, hey, doc, I'm waking up every few nights. Most of the times I'm seeing somebody for BPH. They've had a catheter placed. They've had it in for some time. And so that's why the first step is always history and physical. Find out, hey, like, what's your big bother? And then start talking to them about those steps, right? For me, the big, or about the treatment options from there, going from the full spectrum of observation, just behavioral modifications about what they're drinking, the beverages they're having, to medications, to some of the missed options. And I'm already starting to break this all down, but it's just a history, get their story, find out the life that they want to live, and focus on their problem to give them the therapy that's going to focus on that solution instead of a blanket, one hammer, everything's a nail when you only have a hammer kind of thing. It's just trying to give them all the options and focusing on their story, if that makes any sense.
So not really a one-size-fits-all approach is what you're saying.
No, but that's the interesting thing about HOLUP, right? Is because it fits all sizes.
All right. I see what you did there. That's good. That's good. That wasn't planned, but we'll take it.
Yeah.
I think it's a good segue then for Becky. Are there any diagnostic tests that are useful or that you would routinely get in a patient with suspected BPH?
Sure. The main thing that I want to have for every patient is the prostate size. I think that's sort of the most important first step. There are some other tests I like to do in the office. There's a test called uroflow where you can measure the strength of someone's flow and you can see, how weak it is and sort of help gauge how obstructed they are. You can measure their post-void residual, see how much urine is left over in their bladder. So those are some basic tests I'll do. But I think the biggest thing that I really need to know is what size the prostate is, because if their prostate is less than 80 grams, then I think they're, maybe a good candidate for medications or a more minimally invasive approach if that's what they're interested in. Whereas if their prostate's over 80 grams, then I think an enucleation procedure is really the best option for that patient, sort of irregardless of age. So I think, having the prostate size, a lot of patients will already come in with the CT scan or an MRI. And if they already have that done, I don't need to repeat it. But if patients don't have any sizing, then I'll usually do an ultrasound of the prostate because there's no radiation and I can do it myself in clinic. And often at the same time, I'll do a cystoscopy, which is when you look in the bladder with a small camera. This is most helpful for me in prostates that are less than 80 grams to see if they'd be a candidate for a more minimally invasive treatment, sort of get the shape and size of their anatomy. So I don't necessarily have to do that on everybody, but I think, like I said, the biggest thing is just having the prostate size so you can sort of categorize people into which group you feel they would do best with.
That's a really interesting thing you bring up about the cystoscopy and the ultrasound, right? Because at the VA, when I was a resident, it was like the combo. You do the front and the back, right? You get the cysto, find out what you have. After you've done the ultrasound, you've had a size. But here, we're relying so much on MRIs. And so typically when I'm looking at prostate size, I'm just looking for that CT, looking for that MRI. And then if we don't have it, just because of the logistics, I'm just well, let's get you an MRI and let's see what it shows just to make sure we're not missing anything else. But how often, I guess, do you get to just add them on the day of it at your place? Is it something that you get a lot of fight or do they get to come scheduled that way?
I mean, I don't usually add them on the day of, but I find that if I have them come in for an appointment where we're sort of just talking about their symptoms, I can spend a long time with them just going over their symptoms, then sort of giving them the options and being this is, options are medications, minimally invasive procedures or surgeries, but I can't really choose what's best for you until we do the cystoscopy and the ultrasound. So I give them a lot of information on all of those options that they can go home then and read. So when they come back and we do the ultrasound and the cystoscopy, I feel like they come back with really informed questions and they sort of understand the options. And so it is 2 visits, but I feel like the patients usually appreciate both visits because they're a little more informed on the second visit and it gives me more time with them. So like I said, I don't do it on everybody, but a lot of the men who come in with MRIs just need a HOLUP anyways. So I think that's more for men who are coming and seeing me a little earlier on, men who haven't had any urologist yet and are sort of getting established with a urologist.
Yeah. And I think that's the thing about the patient population that I'm getting referred is I'm only, 8 months, 6 months, 7 months in. I'm having bad time counting here. But everybody who I see is already elderly, large prostate, retention, CIC, with a catheter. And I'm just like, well, we've got a size. We already know what we're doing. The PSA, the more important conversation I have with a lot of the men here is about their PSA, incidental prostate cancer risk and things like that, just because I know they need a HOLUP based on what you said. Like, yeah, they've got a size prostate that's the right size. And so then that becomes part of the conversation. It starts getting very interesting. But now that you're bringing back those memories, like how many of these guys should I just, cysto ultrasound? It was such a good day at the VA whenever you had those procedures, because then you could be like counsel them straight away and let them know, as opposed to like waiting and get the test back and the bureaucracy and things like that. So yeah, it's a lot.
Now, one thing I haven't heard you guys mention is urodynamics. And I thought of it when Dr. Antar was talking about sort of the older patient with the chronic Foley or CIC. Is there a role for urodynamics maybe in some of those folks that you're trying to sort of assess bladder function, or is there some data that's emerging to suggest that maybe urodynamics is not as useful as we had once thought?
You want to take it first? Yeah.
Well, keep an eye out for some papers coming. Yeah, sure. I'm about to write a paper about this. We are presenting some data from Atrium at the Southeast section, which is coming up in a few weeks, I think it has about 110 patients that I've done who were fully dependent before, basically showing that there was no difference in outcome between patients who did or did not have urodynamics. So personally, I don't get urodynamics in any patient in urinary retention unless I feel strongly that they would do very poorly with surgery and I want to potentially convince them that they should just have a catheter for the rest of their life. I would have to go back and check. I would say I've probably done about 130 to 140 HOLUPs in patients with indwelling Foleys or CIC. And of all of those, I only have one patient who caths himself once a night, and everyone else is voiding spontaneously. So I feel like if patients don't want a catheter and they want a chance at being able to urinate, I just think a urodynamics is a little bit of an extra step that I wouldn't necessarily get in those patients. I do get urodynamics in patients with really significant urgency complaints like overactive bladder, significant urge incontinence. I think it just helps me counsel them on their bladder capacity, their bladder function, decide if I want to do Botox at the same time as HOLUP. And I think it just helps me counsel them better preoperatively that their OAB might not be fixed by the HOLUP. So those are the patients that I get urodynamics on, but I have to say I don't get urodynamics very often.
Ali, do you agree? Or
Yeah, I agree. And it's a very interesting patient population, right? I want to watch my words carefully here because I don't want to offend Dr. Grimes. Like Matt, he does so much UDS and he's so good at reading them. And he's like a wizard when he reads them. I've read some of his tracings and things like that. But it's an interesting conversation. I just did a patient today who had a UDS that was equivocal. It wasn't sure, but he's CICing. He's getting Botox, and he's just like, I just don't want to catheterize anymore. And that was the conversation I had with him and his wife. And they were like, I can't promise you, based on this, that you have definite bladder outlet obstruction. But if you're desperate for this, we can give it a shot. We got the MRI. It was 30 milliliters, 30 grams. Just like, do you still? And they're just like, please, any chance at getting this catheter and to get us to stop CICing. So it's a very interesting conversation to have with patients. And then most of the times when my patients have UDS, it's because they've seen Matt Grimes first, and so or Frank Lynn, and they'll get a UDS, and then based on their read, they'll say bladder outlet obstruction. I'm like, thank you, slam dunk, let's do it. But Matt's also still doing his HOLUP, so it's a very rare thing that his bounced to me. So
it works even on those small glands, though. That's what I think. That's what's so impressive. I've had people who come in with 4 liters in their bladder. And then I do a HOLUP and, we get them down to a post-void residual of only, 500 milliliters. So I think that's part of the interesting thing, to quote Dr. Bushman way back. We don't really understand BPH very well. Like, why is a 30-gram gland causing such significant retention? And then patients with 150-gram glands may not have any symptoms or they empty completely. And I think, it has something to do with the capsule or fibrosis. We don't really understand the histology, but as we'll continue talking about, I think Ali and I are big proponents of HOLUP because it just seems to work on everybody.
And anytime you can quote the great Wade Bushman, I think we'll take it. So
yeah, I kind of agree.
That's a perfect description.
Every time I hear about this guy, I'm like, this is like the most interesting man in the world. Like everybody's got the crazy. Hear stories from here, hear stories from here. Like I met him once at the AUA. Man, I need to have a conversation with him.
Yeah, He's interesting, that's for sure.
Yeah.
All right, I want to switch gears a little bit. I know you guys are chomping at the bit to talk about surgery for BPH, but there are medical options out there for BPH as well. Anything new or exciting in the area of BPH medical management? I'll toss this to maybe Dr. Antar.
I think we've been using alpha blockers and ARIs since forever. Actually, I think I have a video urology times. I think this was actually one of my favorite pictures. But I don't know if you can see, it says only Proscar finasteride, 5 milligrams. And then when you play it, it's one of the craziest things. I found this in the office and I kept it just because I thought it was hilarious.
Is that a VHS
It's
tape?
a VHS tape I found in the office, and I'm just like, I'm not throwing. I found a VCR. I transferred it to digital.
Oh.
It was so great. There's actually a very interesting thing on here. It was visual laser-assisted prostatectomy under local anesthesia. They used to call PVPs laser-assisted prostatectomy. I'm like, what a lie. There's no ectomy there. You're just melting prostate tissue.
I'm too young. I don't even know what a VHS is. That's before my time. Just kidding.
The Gen Z crowd's going to identify. No, but yeah, I think the most exciting thing on the medical therapy front is getting you off of your medications, right? And that kind of pushes it towards MIST, towards the UroLift push, and towards the Resume push. Because honestly, these medications all have side effects, especially if you're a young guy. You don't want to have the end ejaculation or retrograde ejaculation. That's another interesting thing about the mechanism there. In my mind, it was always retrograde ejaculation, but I just got in an argument with somebody that said it's anejaculation. I'm just like, wait a minute. It's always been retrograde. So maybe I got to do a little bit more like basic science reading on BPH. But like Dr. Bushman said, none of us really understand it. So I don't know, we'll get some answers. But I think that's the most exciting thing. Dan, he's been leading a charge and a big push to get the primary care doctors here at the University of Wisconsin to be bringing it up much earlier with these guys. Because him and I both are seeing these guys late in their presentation. Their bladders are already almost dysfunctional. They've got a catheter in, and then you have to wait for them to get to their whole-up appointment. So then it's like another 3 months. And by the time you see them, it's been 9 months with a catheter. So we're trying to lead this charge to get people at a younger age be considering the MIST therapies. And then we're trying to transition those MIST therapies into the clinic, which is a pretty big task at an institution like this. But I think Dan's up to it, and I'm just trying to help him as best as I can.
I think there's been some newer data showing some concerns about some of the long-term side effects of these medications, alpha blockers, maybe less so 5-alpha reductase inhibitors. Dr. Gerber, any thoughts on the sort of the long-term implications of alpha blockers? Or I know anticholinergics as well have potentially have some cognitive effects. I talked about that a little bit with in one of our earlier podcasts with Frank Lynn and Vic Nitty. What about alpha blockers? Long-term side effect concerns?
Well, as the daughter of an ophthalmologist, I would be remiss if I didn't mention floppy iris syndrome, because although urologists don't think it's a very big deal, let me tell you, Dr. Steve Gerber says it's a big deal. I mean, it is like a real issue during cataract surgery for those patients. And you can get it if you just take a few doses. So, all men as they get older get BPH. Well, a lot of these men also get cataracts. I think sort of what Ali was alluding to, it's not even just like the long-term side effects of the Flomax or the finasteride. It's the fact that you're not really relieving that bladder outlet obstruction. And then your bladder is being obstructed for years and years. And I don't think that we fully understand how quickly that progresses or at, what rate it progresses. But we've all looked in bladders in patients who are obstructed and have, trabeculations and diverticula, and their bladders just look terrible. And, their bladder probably didn't look like that 15, 20 years ago when they were started on their medication. So I think the biggest thing for me is just the longer that men are on these medications, the less likely that their bladder is really getting the relief that it needs, and the more likely that it will continue to progress and lead to things like overactive bladder. And then you're on anticholinergics, which are certainly associated with many side effects, including, possibly dementia. And so I think getting people unobstructed earlier just helps their bladder overall.
And I think one more like long-term thing, now that you bring up a long-term idea, post-finasteride syndrome is something that Dr. Kira, who was also a Lipschultz fellow like Dan Williams, he was studying a little bit when I was still a resident. He had a little bit of early traction. I'm not sure exactly where it dropped off, but it was some interesting stuff on the depression scores and things like that about men who had finasteride either for BPH or for balding and the emotional effects that it had on them. So it's not a nothing burger to be on finasteride for a long period of time and then to come off of it which is another interesting thing. Maybe we should look at some of our HOLEP patients that were on finasteride for a long time and see, hey, did anything happen after we fixed their bladder outlet obstruction and then they took them off the finasteride? Did it affect any? It's the hormonal emotional dysregulation, I think, that they were talking about. So.
Very interesting. Now, when you mentioned balding, you pointed to your head, Ali, but I thought that was all real.
It's a piece, that's why the headband, because I can't let people see the.
I mean, it could have fooled me.
Yeah,
I'm kidding.
No worries.
And, now, I wanted to move off medications and sort of get into more of the procedural side of things.
Thank
right?
goodness.
There's a lot of procedures. Right. About time. Yeah. There's a lot of procedures out there for BPH. And you used the term MIST, which I think I know what that stands for, but maybe you could tell us a little bit what a MIST is. And are there any MISTs that you have experience with that you wanted to highlight?
Well, I've never personally gotten any MISTs. Okay. Minimally invasive surgical therapies,
You're
right?
too young for that.
I always start, the balding, no. I always start worrying about if I'm like overlooking an acronym, but I'm pretty sure that's what it is. Minimally invasive surgical therapies. The one I've had the most experience with is Urolift. We did a lot of that at the VA when I was a resident. We're starting to do it now too. There's the sequel to Urolift 1, Urolift 2, with the reusable clips. It's because before you used to have to change out the whole device, because it was the action piece. It was a whole device. You had to take the whole thing out and then put a whole nother gun in. But now the gun has changeable cartridges. So it's a little bit friendlier for the environment, but I guess it's also a little bit cheaper, reduces the cost. And also, I think the click mechanism is a little bit easier, a little bit more straightforward than the Urolift 1. So I did one of those with Gralnick. Gralnick is really starting to ramp up his Urolift practice because, again, we've been teaching HOLEP for a long time, and he's a jack of all trades. We're going to bring the full BPH therapy around. I'm not really a big believer in Resume. I'd done one in residency, and I think I did the first one there at the VA, and I was just like, I think I'm good. Something about it just doesn't feel like I'm really treating the prostate because it's like 7 seconds, and then you go up again, and it's like 7 seconds, and I'm just like, that's it? Like, what happens next? I don't think we put aquablation under here. I think that's a different discussion for a different portion of the talk, unless Dr. Gerber, you want to comment on those. You might have more experience with the MIST than I do because we're really only starting to ramp up the Urolift now.
Yeah, I mean, I actually tend to favor Resume over Urolift. I like that the Resume is actually like removing some tissue. Now, granted, it's definitely not removing as much as a HOLEP or an aquablation, but I'm able to do Resume in clinic, so it's a nice minimally invasive option for patients. I use nitrous and do a prostate block, and I do think that the urinary tract symptoms are a little worse initially and a little more urgency and frequency and dysuria as things are healing. But I've actually seen people do pretty well after Resume, and I've scoped I've performed cystoscopy in some people after, and it actually does a pretty good job, better than I thought initially, of opening up the channel if you deliver it in the right spot and do enough treatments. So I tend to favor Resume over Urolift. I've just taken out quite a few Urolifts and seen them in the wrong place, or I think both Urolift and Resume have a place in BPH, but I think sometimes they get utilized in patients with bigger prostates or unfavorable anatomy, and I think that's really where the issue lies. I think that's why I think it's so important to do a cystoscopy before, because if you have like a high bladder neck, Resume's not going to work as well, and neither is Urolift. And so that's what, iTind is coming around sort of to address that factor, potentially. I haven't done any iTinds personally, but that's what it's marketed for. But I think there is a niche, a small subset of patients who are good candidates for Resume and Urolift, and I do not think it's everyone. But I think it's good to be able to offer those for patients mainly because of the lower risk of ejaculatory dysfunction, which some men are very interested in maintaining. And I think it's important to respect that and listen to that, want in patients. And I usually will do Resume in those cases.
A little selfishly, though, you mentioned the nitrous, because we went down to Austin and we saw one of the private practice urologists out there with his nitrous practice for Urolift. What was it like for you getting nitrous? Is that something that already existed, and how does it work for your patients? Because we're again also leading the charge on that one. He's doing a really good job. We're making some headways, but it's something we're trying to get soon.
We already had it when I showed up, so I just was lucky, and we have it. And It's really helpful. I don't use it for vasectomies. I just use it for resume. I give them Valium and nitrous and do a block. And I mean, it's still a little uncomfortable for them, but I think that it makes it tolerable.
So yeah, the ultrasound in when you do the block and then pull out and then you do the resume. Mm-hmm. Nice. That was actually something that they did mention in this VHS, which, for the laser prostatectomy.
Not much
I was
has
like,
changed.
man, they did blocks. Look at that.
So it sounds like what I'm hearing from both of you then for these minimally invasive office-based procedures is patient selection is critical.
Absolutely.
There's certain patients that maybe are good candidates for resume that would be better candidates for UroLift or maybe the iTind, which is coming down the pike. So no experience yet with iTind, Dr. Gerber?
No, I can't. I mean, just the thought of leaving it in the patient for 5 to 7 days, it seems like it would be pretty uncomfortable and like a lot of patient phone calls. But one of my partners is doing it, so I might let him sort of take the lead there. I will say, I know this might be a question later on, but I'm going to jump the gun a little bit. I am pretty interested in Optilume, the BPH Optilume balloon that they're coming out with. I've been meeting with some of the reps, and I think we're working to get it approved at Atrium because, as I mentioned before, there's some patients who have a really tight bladder neck. Like their prostate is not huge. It's maybe like 30 to 60 grams, but their bladder neck seems really tight. And this balloon that they've come out with dilates the prostate and the bladder neck. In patients who want to try something minimal, there's not a lot of risks with balloon dilation. It can be done pretty quickly and low side effects, and you don't need a catheter for very long. So I do think that's something really interesting coming down the line that I'll probably offer to my patients and sort of see, the preliminary research is definitely interesting, and it's just so low risk and so minimally invasive that I don't think there would be like a lot of harm in trying it.
Yeah. I think Matt's trying the Optilume now for some of the strictures. And so I wonder how hard it would be for us to get that.
I do it for the strictures.
Yeah. But I wonder what it would take.
I mean, for the strictures, it works really nicely. So that's kind of why I use it for strictures, and it seems to work really well. Yeah. And so, I mean, it's a little bit of a different mechanism because it seems a little, you're blowing up this balloon in the prostate, but it's coated with the paclitaxel. And I really think that dilating the bladder neck would be helpful. So that's something interesting coming down the line.
And I think back to just real quick on the patient selection thing, the main things are for urologists and younger guys wanting to get off their medications, wanting to preserve ejaculation. I think those are the big key triggers for me. But like, oh, okay, maybe we should do that. Especially when they have the much smaller prostates, the 30 grams or something like that. Because you could hole up that, but it's just quicker to do this. And then you could always do a hole up afterwards. Let's say that it doesn't work or it fails, the hole up is still on the table. I haven't done any post-resume hole ups though, but have you?
Mm-hmm. That's no problem. Honestly, it's easier than the UroLift because it hasn't really gotten into as deep. So your planes are still the same and there's no like clips sort of distorting the prostate. So it's a little easier than post UroLift.
Makes sense. Maybe I have to reconsider my stance on resume.
Well, and do you counsel these patients then, Becky, that, what's the retreatment rate that you would expect in somebody that has resume or a UroLift? In your experience?
Well, I've only been here for 2.5 years, so far 0%. But I think, when I'm quoting the literature, I sort of go over with them that these are newer technologies. We really don't have much data past like the 5 to 8 year mark, and we think the retreatment rate is somewhere between 10 to 20%, but that's not perfect. And going down the line is probably going to be higher than that. So I'm pretty frank with people that like this isn't permanent. Like this is a temporary solution. It's almost all men are doing it because they want to preserve their ejaculation. So it's like, look, you want this now, we'll do it. It'll maybe buy you 5-10 years. And then in 10 years, when you are okay with, moving on to the next step and not as worried about ejaculation, then we can move on. So I'm pretty upfront that like, this isn't going to cure you, but it will help you and get you off medications for a period of time until you're more comfortable doing something more invasive.
A really great discussion on minimally invasive office-based procedures or MISTs. I wanted to get into the operating room now. That's where we have also a sort of a plethora of options. We've touched on some of them already. Where does TURP stand? TURP, TURP was sort of the lion's share of what urologists did for decades. Ali, is it outdated? Should it be done? Or where are we at with TURP in 2024?
That's a good question, right? Because if you look at most studies now, it's still the lion's share. It's because there's a lot of urologists in practice and there's still a lot of the fear around HOLUP. In my opinion, I think as we're moving forward or educating the next generation of urologists, I can't justify not teaching them the more definitive surgery just because it's a little bit harder to teach. And we can get into the learning curve discussion in a while, but I do still think it has a place in the education, just in terms of mechanics and understanding, because you want them to get that comfort with the resectoscope and with the loop, especially if they're going to go on and be general urologists, because they're going to have to do TURBTs. So you want them to start getting that facile motion, and that's the best place to start. You don't want them to start trying to learn how to use the resectoscope when there's like an anterior tumor and it's huge and hanging down, right? You want them to already have that facile understanding and have that be a second nature. So there is a place for the TURP in that education, especially in the smaller prostates, and you don't want to take that away. But if you're really thinking about the long term, I mean, when TURP was first developed, and maybe this is where having Bushman around would be great because he'd maybe have more insight, but like, TURP was one of my old attendings at Baylor who had been around for a while. He mentioned, that TURP is a chief level case, and he still viewed it as a chief level case when I was a PGY4. So he wouldn't let the junior on it. He wanted me there, which is a very interesting thing because there was like robotic cases going on. Like, I'm not going to do a TURP instead of a robotic case. That's an actual chief level case, right? But that's what they thought of it as because of TOR syndrome and the risk, right? Because if you're not moving fast enough, and if you don't have the technology that we have now and you're kind of bent over looking at it, it's a pretty hard surgery with a lot of bleeding and a lot of risk if you stay there for too long, right? Which, if you think about HOLUP, that's the kind of stuff they say about HOLUP all the time, right? But we overcame that with TOR, and now it's the lion's share, and it's the primary standard procedure that most urologists do. But it was over time, right? And that's how that change happened. And so I keep alluding to the discussion on the HOLUP learning curve. But if you ask me, I really think that's where HOLUP belongs. If it's the more definitive procedure, any size prostate, right? Because you don't want to do a staged TURP. You could do a HOLUP in one go. I don't see why you would continue to teach TURP as the primary procedure for the next generation of urologists over HOLUP. It just doesn't click in my head, especially with the experience that I had learning it with Dan and Chris. So
I think that makes sense. Now, Becky, I want to flip a little bit to lasers. Urologists love lasers. There's no question about it. There's many different types of lasers, right? There's the HOLEP, which we talked about, holmium laser. There's the thulium. There's a green light laser. So where do lasers fit in the management? Because for those that aren't familiar with TURP, that's electric cautery based, so not laser based. But so where do lasers fit in?
Yeah, so for people maybe who aren't as familiar with urology, a TURP, when you're going in with a TURP, you're basically just scooping out from the middle. So if you think of it sort of like a donut, you're going through the middle of the donut and then just scooping out from the inside. And that's the same thing, like you mentioned, a green light laser or called a PVP, a photovaporization in the prostate. It's the same idea as a TURP, but instead of scooping out the prostate, you're using the green light to basically ablate it. But then there's technologies like the thulium and the holmium laser, which were initially, like back in the late 90s, used for ablation. But then Peter Gilling, who's from New Zealand, basically pioneered this technique called the HOLUP, where you're enucleating the prostate instead of just scooping it out from the middle. So we'll use a different food. If you think of the prostate like an orange, which I'm sure everyone has heard this analogy by now, but you're basically using the laser to remove all the fruit and just leave the peel behind. So you're shelling out essentially all the blocking prostate tissue. And when you use the laser, it allows you to get hemostasis as you're removing the tissue. So it allows you to get good control of bleeding, and you're getting in this really nice plane. So you're removing all the blocking prostate tissue, which is a little different than a TURP or a PVP. So I think the use of the laser, a holmium versus a thulium, is a little bit user dependent and just partially depends on what you trained on. We always use the holmium, and I find that I'm the most comfortable with that. I've used the thulium too, but it chars a little bit more and it's just sort of a different technique. And so I've always been partial to using the holmium, but you can do the enucleation with the holmium or the thulium, so a HOLUP or a thulip, and I think both have great outcomes. So it's just a bit of a matter of what you feel most comfortable using or what your hospital has. Luckily, we have both, so no shortage of lasers where I am, but I use the holmium unless something happens and it's not available, then I'll use the thulium.
Yeah. I tried the thulium out, the TFL, on one case at the VA, and I within the first 5 minutes, I'm just like, this is not right. because you know that you get that nice split and things are opening, right? With the thulium, it's doing is just pushing it in. It kind of just like compacts things. And I'm just like, that's the opposite of what I want. I really want it to show me more. So you use the beak, you get that nice plane, and then you put the thulium on it and it like closes it. I was just like, no, that's not what I wanted, you know?
Yeah.
And so I didn't like it at all. There's a thulium YAG laser that I was trying, the Thulio. And I tried it. I was able to get the cases done. And when I switched back to the hole-up, I was just like, oh, this is definitely flying much faster. Because the Thulio was kind of like an in-between where it was splitting, but it wasn't splitting to the extent that the holmium was. And I was putting it on the same settings, really. I think it's just the nature of the wavelength of those specific lasers. And so I definitely was like, no on the TFL. I mean, we're still making choices here, but if the Thulium mag is around, would I still use that over the holmium? Probably not. And I think there are other lasers like the Quanta and things like that other people also like, but I've never tried those.
Yeah, the Quanta and stuff, but those are holmium still.
We have a Quanta now, but I don't know if it's a high power enough. Yeah. I don't know if that's going to be capable of an enucleation, but yeah.
They have a Quanta that goes up to 150 watts, so they have a higher.
Yeah, I don't think ours goes that high.
Just to go back to one thing Ali was sort of touching on about the TERP, I think that TERP is still a useful technology because so many urologists understand and know how to do it, and it's accessible at every hospital basically in the country, whereas a holmium or a thulium laser is expensive. The equipment for the hole-up is expensive. So it's definitely still useful. I think one of the arguments that a lot of people use is the time it takes to do a hole-up. And I think that as you become more proficient and you do more cases, that time doesn't become a factor anymore. I did 4 hole-ups today, and none of the cases, like from start to finish, took more than 60 minutes. So I mean, they weren't giant prostates, but they were all between like 30 and 70. And so any TERP would take at least that long, like at least an hour to do a 30-gram TERP, probably longer than that. It's hard at the beginning when you're learning because of the learning curve and you're not as efficient. But ultimately, if we train all these residents and all these learners how to do hole-up, it's sort of like Ali was saying, like how TERP used to be viewed as this really challenging case. That's how hole-up was viewed. But all the residents at Wisconsin are learning it, and they are amazing residents. And I learned it in residency. It's clearly something that can be taught and learned in residency, and you can become efficient within your first few years of practice. And so I think like a lot of the arguments that people make are based on not having seen it or learned it or like been in a program where it's so present.
I love the technology and the cost argument, because I mean, if you think about another analogous surgery like a radical prostatectomy, if you look at the cost argument, how much more does it cost to have a robot, and how much more available is just a retractor and open surgical tools? But nobody's being like, oh yeah, let's keep doing open radical prostatectomies. It just costs too much.
Well, they were at the beginning.
Well, yeah,
but now
and it just takes time sometimes. And so like I'm glad to have caught hole-up at the time that I did to catch this wave, but I really do think it's the future. So sorry, I cut you off.
You're going to have my job pretty soon, I think, Ali. So we're looking for a new host of WInnovations. So we're going to put out a call. But no,
we
just got two people who like hole-ups, and you can't stop us from just talking about it.
I think the other point too is when you talk about the learning curve, which is steep, but you can also say it's steep for robotic prostatectomy, an operation that I perform. But the residents, you train them and they get good at it, and they go out and they start doing robotic prostatectomy in practice.
Exactly.
We need more folks like the two of you, coming out of here and going into academic programs so that they can train other residents. So I think kudos to both of you for realizing that and doing that. And I wanted to ask Becky, because she's been doing this a little bit longer than Ali, just a little bit, just by a year and a half. So when you went out to Charlotte, you had to start a program, right? Pretty much from scratch, which can be intimidating and similar to what sort of Dr. Gralnick did here at UW. So how did you do it? How did you approach it? And how did that go?
That's a good question. So fortunately, before I started, one of my partners, his name's Mark McCooley, was interested in learning hole-up and had already started sort of the fight of getting the hole-up equipment. So once I got there, we had 2 trays. We had 2 hole-up trays. And I had done 150 hole-ups in residency. So you're always nervous being on your own, but I felt like I was well equipped with my surgical skills. And I knew I wanted to start with smaller prostates. So of course they were like lining up these like 250, 300 gram glands for me. They're like, Dr. Gerber is going to be here in 3 months. Like, here are these patients for you. But I was, those are not the best patients to start with. And so I sort of built up my first 10 or 15 with, 80 to 120 gram prostates. And I didn't really have the residents participating a lot in my first, 20 to 30 cases, because I just wanted to make sure I was getting, my feet off the ground and everything was going well. I was also teaching my partner, Dr. McCooley, at the same time. It was helpful just to sort of have another voice there, just because it's always helpful to have another person. So he would be there for some of the cases. And then I just got busy really quickly. And so I fought for more trays. And so now we have 4 trays at 2 different hospitals, and I got busy at one hospital. So I fought to like get a holmium laser at another hospital, and just kind of like kept pushing and kept showing how busy I was and how much it was helping patients and the need, and how helpful it was for the residents to learn. And so I think when you're starting, it's important to start with reasonably sized prostates and not get discouraged. Start with 60 to 120 grams. Don't start with giant ones that are going to be harder, bloodier. Don't start with patients on anticoagulation. And then I think take your time when you're starting. You don't need to rush through the cases when you're first starting, and try to be as efficient as possible. You go through, you see where your planes are, you keep double checking things. And there's always people out there. There's always resources. Wolf is definitely good at helping proctors, and Boston Scientific is good at finding proctors. So I think, finding a proctor and someone that you trust and can troubleshoot with is really helpful. We have a group chat at Wisconsin. That's me and Grelnick and Manicus and a bunch of the residents that do hole-ups. And that group chat has people texting it almost every single day about things. And so I think having support is really helpful. And once I felt more comfortable, now we go through it with the residents, just like I did at Wisconsin, and they go through step by step. And I think almost all the residents have done at least one on their own, and the chief has done like 15 to 20 on his own. And I've only been here for 2.5 years, so it's like a totally reasonable thing to be able to do. You just have to be confident and start small and go bigger from there.
I think that's great advice for young urologists and maybe trainees that are listening in. What about you, Dr. Antar? Any advice for those maybe younglings that are transitioning to practice?
I'm still taking all the advice I can, man. I'm like less than a year out. But it's interesting because I've been put into a very interesting position because, the way that it's here, for those first 5 months before I started doing cases at the VA, I was just in the house that Dan Gralnick built, right? And so the way that the water was done, everything was set up. The Morse later worked fine. But I go to the VA and you have a team that hasn't done it before. And I think this is one of the more important parts about teaching whole-up and just teaching surgery in general. Like, surgery is a team sport. And like we like to focus on the quarterback, right? Like, oh, we're the quarterback, we're going to make something happen. But it's a team sport. And so there's the offensive line and there's the receivers, there's the running back. I guess you can look at the circulator as a running back. It's like, oh, go get me my tools or something. But it's a very big team, a lot of moving pieces. And if you're not able to direct the whole room, then good luck doing your job, right? And so at the VA, it's been an interesting thing with fluid management because they have the Thermodex, the Stryker fluid management system, which Dr. Gerber would be interested to hear your opinion on that. Because I don't know if you're still doing the Gralnick four bags to the ceiling. You use the Thermodex?
I have a Thermodex and it's amazing. I have it at both hospitals. It's essential.
What settings do you put it on?
I use the pressure at 60 when I'm enucleating, and then I turn it up to 75 for morcellation.
I just been cranking it up to 90 from the start, and now I'm wondering, I hope I'm not hurting anybody.
I think that's Gray Roberge. I think he said he does it. There's not like a specific answer. I think I talked to a few people, and that's what they said, and I was like, okay, and that's what I've been using, and it seems to be working well, and I haven't had any issues. So that's a great point, though, about having a good OR team. It's really important for the whole-up to have like a OR team who understands what they're doing, like the circulator and your fluids. If your fluids runs out while you're morcellating, that's a huge issue. And so making sure your team understands the importance of what they're doing, that's a great point.
Yeah, and so Gralnick and I were talking about that in my little brainstorm office here about like, hey, what would that curriculum look like about teaching the room? Because we were also listening to another podcast. It was like on the Journal of Urology. They were talking to a hole-upper in England. And he was talking about, like when somebody's interested in learning, I ask them to bring their whole team. Like you can't just come as a surgeon. You got to come with your scrub. You got to come with your circulator so that they understand the equipment just as well. Because then after I got over the fluid management system, we got to the morcellator, and I'm just like, the morcellator is always just handed to me and it works great. And now it's just not. So how do we troubleshoot the morcellator? And if there's any like avenue in terms of developing hole-up technology, if somebody can beat the Wolf morcellator, I think they'd stand to make a good amount of money. But, we'll see. Because there's just a lot of places where it can go bad, but it's been working pretty well so far. So
I was just going to say that's a good option for innovation right there is the morcellator, right? I mean, there's a lot of things that we observe in our environment, operating room, that can be improved upon. And that's certainly one that I hear a lot from hole-uppers. I've not heard the hole-uppers before. Is that a common terminology?
That's actually... It's a common terminology for Dan Growlick in the state of Wisconsin now. So he's also Dan is. It's interesting you called me a thought. Maybe Dr. Gerber, you're definitely a thought leader. You have a lot of good thoughts. I'm just a thought haver. Dan Growlick is the actual thought leader. He's pushing forward a lot of the ideas with regards to the other treatments of BPH.
Yeah, he really is.
Yeah, and the hole-up group here in Wisconsin, that's what we call it, the hole-uppers. It just makes sense. The acronym is, I can't remember, Wisconsin hole-uppers doing extra special prostate surgery. Something like that. Hole-ups. I got to go look it up now. I'm so bad at acronyms, but it's Dan's his very valuable project, and I'm just glad to be a part of it. So we had our first meeting, and it was wonderful to talk to other people very passionately. Kind of like right now, asking about the Thermodex. That's why I was so eager to hear, like, hey, what do you put your Thermodex on? Because I only just started using it in the last few weeks, and I really like it. I think it's great.
I love it because it dings when it's running out of fluid, and so it's just like another thing that the circulator can hear instead of just having to watch the bags run out. So I think it's been invaluable. I use it all the time.
And then it's super easy for them to change. They don't have to like climb the thing up and then climb the thing down. It's just they hang one, they plug it, hang the other, they plug it, and they just set the buttons on the screen. So I like it a lot.
Well, I think that's a good place to end. I think we're running out of time, but this has been great. I want to thank my guests, Dr. Antar, Dr. Gerber. You guys have been fantastic. So thank you so much for being on the program.
Thanks for having us, Dr. Richards.
Yeah, thank you so much. I really appreciate it. It's always good to talk.
Nice to chat with you again.
Yeah.
Of course. Yeah. Keep up the great work in North Carolina. I know Dr. Antar is doing great work here in the great state of Wisconsin. I want to thank the Department of Urology, Dr. Nakata, our chair, Sandra Miller, our producer and editor. It's been really a great run here in season 2 of WInnovations, and I bid you all adieu on this fine evening.
WInnovations is a production from the Department of Urology at the University of Wisconsin-Madison School of Medicine and Public Health. Thanks for listening.